Thank you, Samanya. Friends, welcome you all to this a very new kind of series we have launched from today. Maybe I can call it sub-series of the ICS Wednesday seminar series, because in this new sub-series, we're going to bring up issues which are generally not reported widely in the press, international press, or also do not get much attention in the academic discussions outside China in particular. And focusing on basically series of social problems which China has been facing, in particular since the implementation of reform policies began 4 decades ago. And so this sub-series will come up with issues of this kind from time to time, maybe once in two months or once in 6 to 8 weeks or something. So today's is the first in this series, and it is on something in Chinese called Yinao, or in English it has been variously translated as medical disturbance or medical violence or medical ruckus, etc., etc. I mean, I will introduce this shortly. What is this Yinao phenomena, or whether it is unique to China? But before that, let me also reiterate for those who have been regular in our webinar participation that during the question answer session, there are two ways you can ask your questions. You can either type in and send it in the chat box, or you can click raise hand in the participants box, and you can ask your questions yourself rather than typing in. So with this, I go back to the theme of this today's discussion, which is Yinao, commercialization of healthcare in China, the growing medical ruckus menace. Now, let me quickly introduce the topic. We initially had thought that we will have the conversation format for today's discussion. So I will begin by introducing the topic, and then perhaps I'll put up a couple of questions to both our experts. But before that, yeah, I should not forget to do my duties of introducing the expert speakers. We have two experts today, Professor Maitrayee Chaudhuri and Dr. Madhurima Nandi. Maitrayee Chaudhuri has been teaching at the Center for the Study of Social Systems, JNU, since 1990. She has written widely on feminism, media, academia, and pedagogy. Her key publications include The Women's Movement in India, Reform and Revival, published in 1993 and then reprinted in 2015. She has also an edited volume, The Practice of Sociology, which was out in 2003. There are numerous other publications, which I will not read out because it has been circulated in the notice for today's webinar. But quickly, her most recent books include Refashioning India, Gender, Media, Public Discourse in 2017, and co-edited volume Doing Theory in 2018. She was the first Professor India Chair at McGill University in 2015 and a DAAD Visiting Professor at Albert Ludwig University, Freiburg in Germany in 2003, and a Visiting Fellow at Harvard and Massachusetts universities in 1995-96 respectively. Her recent works have looked at the making of public discourse in contemporary India, shaped by neo-liberalism, majoritarianism, and populism. Besides teaching sociology, she's also been very actively participating or practicing sociology in the form of a project she runs involving youths and students called Doing Sociology. It's doingsociology.com, actually. Then Dr. Madhurima Nandi is Fellow and Assistant Director, Institute of Chinese Studies. She completed PhD in Public Health from JNU Center of Social Medicine and Community Health. Her areas of interest include health service systems, health policies, comparative health systems, and inequalities in health. She has published numerous articles in the area of public health in China and India. One of her most recent publications and an outstanding work along with Professor Rama Baru has been last year's Commercialization of Medical Care in China, Changing Landscapes. It came out from Routledge last year. Besides, along with Professor Rama Baru, Madhurima Nandi is also in India a pioneer in studying and analyzing healthcare service in China. And she has collaborated and conducted various joint projects with health professionals and scholars in China in this field. So with this introduction, let me quickly touch upon the topic for today. Yinao is Chinese coinage. If one can actually go back to the pre-reform China, then we know that Mao's China had provided us with various language goods. By language goods, I mean the slogans and phrases, etc. And in the field of healthcare, one such language good coinage, which everybody knows, I think it's universally known now in India also, that's called barefoot doctor. And that was the result of the so-called egalitarian universal healthcare system in China between 49, let's say, and before the reforms were implemented. Now, in contrast to that, China has given us another language good, which is called Yinao today, which is a result of the reform policies where all the achievements and system of the barefoot doctor or primary healthcare system in China has been completely dismantled and replaced by the commercialization of healthcare in China. And Yinao is a typical product of that policy implementation. Yinao basically is two Chinese characters, Yi and Nao. Yi means medicine or medical, and Nao is basically trouble or to make trouble. And Yinao, therefore, has been coined reflecting on the phenomena of violence happening in China in the healthcare sector, and because of the healthcare system, actually. So that is the background to the coinage. And I mean, due to time limitations, I shall not explain or rather compare in details between barefoot doctor and Yinao phenomena. Let me quickly turn to what exactly is Yinao and whether it is unique to China or it is also witnessed elsewhere outside China. In India, of course, we have Maitrayee Chaudhuri here who will tell us about, and we all know that especially during the COVID 2020 year, we've all seen reports and heard on TV news the violence which doctors were attacked and nursing staff were attacked, hospital officials were attacked, etc., etc. But that can be maybe kept aside as an isolated phenomenon because of this extraordinary situation we are in. But the medical violence or medical ruckus, as it is called in China, to put that in perspective, let me just highlight two aspects of this phenomena in China. One is in 2016, a very popular Chinese news weekly called Beijing Review, which earlier used to be known as Peking Review, had come out with a story, and in that on their website, And the advantage of the website story is that they also had a embedded video in that story. And that video is just, I think, 1.5 minutes video. And it showed a woman crying inconsolably for nearly 1 minute in that video. And then finally, when asked why was she crying, then she says she's crying because she has come from a faraway rural countryside area to Beijing, to one of the big hospitals in Beijing. And for last 2 days, she has been trying to and running from pillar to post to get an OPD appointment with a specialist for her relative who needs to be seen, who needs to see a doctor. But she's not getting an appointment. Why? Because every time she reaches the counter, she's told that the day or the slot she's asking for has been booked in advance. And and this is perhaps typical in China. Even in India, in All India Institute of Medical Sciences, which perhaps gets on average the largest number of people coming and seeking such appointments. I have been there for my father in the past. And the maximum wait, I mean, booking, one can book perhaps 1 month or 45 days in advance, depending on what kind of specialization one is taking appointment for. But in China here, she was told that the appointment has been booked for months in advance. So the reason was not that she is not getting an appointment because it is all the slots are booked. The reason why she was crying was because there have been agents roaming around in that main hall of the hospital and who are offering her any slot anytime she wants in the black market. And the rate on which she can buy an appointment. I mean, the normal appointment price which she was asked to pay was around 250 renminbi for a specialist doctor. And the agents who were selling the slot, they were asking her to pay 4,500 renminbi. And you can imagine now. And then, and then the article in Peking Review goes on to give the detailed analysis of why this is happening in China, basically referring to that in all China's first tier cities, Shanghai, Beijing, Canton, Shenzhen, etc., because all the good hospitals, big hospitals, are only confined to these areas. And in the towns and in the provinces, in the countryside, for miles, there are no good hospitals. Even if you find hospitals, there are no doctors, etc., etc. That's why people had no choice but to come to these big hospitals in big cities. And one of the specialist doctor who was interviewed by Peking Review, is he aware or was he aware of this phenomenon? So doctor refused and he said he was not aware. And when he was told that even for his appointment, 4,500 renminbi was being charged, he said he was completely unaware of this thing because the hospital gives him per appointment 14 renminbi. That is his fees to see a patient by the hospital. So this is, I mean, one reflection of what goes on, what drives this phenomena. And second is, despite this problem actually having been noticed in China from the late 1990s, and in particular since the SARS epidemic in 2003, and Madhurima would bear me out on this, because it was post 2003 SARS that China actually introduced healthcare reforms. And these healthcare reforms were actually privatization of healthcare in China and dismantling the universal free healthcare, etc., of the previous era. So since then, this has been happening. And what is ironical in this is that the Chinese government or the authorities or the party, whatever way you look at it, for them, they claim that social stability is the most sensitive aspect of their governance or their legitimacy, etc., etc. And it is series of social problems in China, starting with late 90s of the three rural issues, which for those who have been studying the Chinese rural countryside, they would know that the three rurals, San Nung Wen Thi, as they say in Chinese, actually it waited for nearly more than 1.5 decades by the government or the party to acknowledge that there is something called three rural phenomena, which the scholars and academics had been writing about since the late 90s. So the same is the problem with various other series of social problems, which I say ironical because one fails to understand that on the one hand, the party or the government gives so much of attention and focuses on maintaining social stability. And on the other hand, it chooses to either neglect or express its total helplessness in overcoming these problems, which have become chronic problems now over the decades. And there is a series of these problems. I mean, you name it. There is gender discrimination. For example, there is a quota for men in China for entrance examination in the higher education institutions and in the employment sector, even today. And then there is domestic violence. Then there is worsening plight of migration workers, rural workers, no wages or low wages. Then there are labor rights issues, retrenchment of large scale of workers from the factories, and education. I mean, Chinese scholars have written about this thing, saying that the Chinese education system today actually has become a vicious cycle of producing and maintaining generation after generation of migrant workers, and so on and so forth. So this is the other aspect. And Yinao, the medical violence, is one such of a series of social problems, which I think have become such a big issue now today because of the neglect on the part of the authorities and the government. Now, with this little background, I think I'll stop here my brief introduction and perhaps begin by asking a couple of questions to Dr. Madhurima Nandi. Maybe I can request her to begin with her book along with Rama Baru, which came out last year, because the title of the book also is Commercialization of Medical Care in China, Changing Landscapes. So maybe, and she has also earlier written about it. I remember an article by her on this medical violence in 2015, way back in 2015. So please tell us about whether it is directly related to the commercialization of healthcare in China, or there are other bigger structural issues which the government, despite the glorification of Xi Jinping's governance style and volumes after volumes Xi Jinping is producing on governance, why this governance is lacking in these areas. So, Dr. Nandi.
Yeah. First of all, thanks, Dr. Adlakha, for bringing this issue up. This has, in fact, been reflected in our book too, though we approach it from the aspect of commercialization of medical care that's been happening in China over the last 3 decades. So the phenomena of commercialization, of course, is in the early 2000s, it starts, but the dismantling of the health system starts just after the economic reforms and the opening up. So in a sense, this whole process of violence in healthcare, as you have pointed out, even though it's a global issue, it has its specificities to China. I mean, the magnitude of it is definitely something that's been worrying and has been reflected in their social media and social different platforms a lot. And in fact, even through films and documentaries that they have had. So the neologisms like Yinao and other various such terms have actually come up post 2013. And in fact, that has been, I mean, that's something that one needs to actually decipher, like what was happening during this time as to bring these violent cases, or at least the increase of these cases over a time. And Yinao especially becomes like specific to China because this is an organized kind of a violence. It's a mob activity where you hire mob to by the patients and their kin to attack the healthcare workers. So I see it at different levels and different layers as to what's happening in the health service system. China, of course, went through quite a dramatic socioeconomic transformation through the market socialism framework that starts in the early 80s. I mean, of course, a lot of the design and the ideas that define the health sector and the development of the health services are similar to what you see in the neoliberal context too. But it happens within this framework of market socialism where the public ownership is retained in the institutions, but the institution itself becomes commercialized. So this act of commercialization actually starts slowly in China by the late 80s, 90s, when the primary level of health services is completely dismantled and the institutions are left on their own to independently work and are autonomy and have a specific autonomy as to be separate institutions rather than being part of a referral structure. So these institutions start generating their own revenue. And a lot of this happens because the government subsidies are withdrawn. The institution is left on its own with just 10% of the income coming from the government, and the rest is supposed to be generated by these hospitals by itself. And these are mostly at the tertiary level. So what is happening at this time is a lot of the rural population and a lot of people in the other provinces are actually moving to the first tier cities to access medical care, and mostly at the tertiary level. So there is a top-down approach that is there. The effect of these things are, of course, the effect at what is happening at the socioeconomic political level comes down to the institutional level. So you see the effect at the institutional sense in terms of the way the behavior of the medical personnel change, the way they, the culture of medical practice itself shifts to being more of what would be based on trust to what actually becomes a very commercial activity where the doctors are being incentivized to generate revenues by increasing their clinical services by over-prescribing or over-medicalization of the practice. And also brings in other corruption issues, like you mentioned yourself, the agents who are selling those tickets at the tertiary level hospitals. And also in other aspects as to where the patient, because of this lack of trust deficit in interpersonal relations between the patient and the doctor, actually where the patient is trying to bribe the doctor by giving what is called that red envelope or the hong pao that they call, to as gift that they call it as a gift that they give to the doctor to kind of, okay, I mean, give us good quality care. So that is what it comes down to the micro level. And when these things start breaking up and at the interpersonal level, so that's where the violence also increases. So violence, as you had said earlier, like it is a global phenomenon. It's not unique to China as such, but of course the dramatic shifts that China sees within the health service development and the structures of it, and basically the interactive relationship between what is happening at the micro and the political level and to the institution and the interpersonal level, it kind of, you can see it as a dialectic relationship that is actually taking place, and which actually sees, and you see violence at a greater level and an increase in these incidents over a period of time. And the 2009 reforms actually become a landmark there because you have greater privatization. You also want to correct a lot of things that went amiss, but you actually move into further commercialization of the medical care itself. So that would be my first take in it. Yeah.
Okay, thank you. Thank you, Dr. Nandi, for putting it in a proper perspective. I mean, related to what you said, let me go back to a report which was carried by Bloomberg News in 2012. And the Bloomberg had headlined this news in 2012 as violent crimes in China's hospitals make many citizens happy. Mm. That was the headline carried by Bloomberg. And then by digging up further, as you said that this particular coinage perhaps came about in 2013 or so. Now, in 2018, China Medical Doctors Association, they conducted 2 surveys. One survey was conducted involving only the doctors, and they involved 150,000 doctors in that survey, and they were simply asked 2 questions: that whether they had experienced any kind of harassment or violent attacks during their service. And out of 150,000, 1 lakh doctors responded positively, saying that they had been subjected to either harassment, and nearly 30,000 doctors admitted of being physically attacked. Okay, this was one. And the second survey was uh, at general. I mean, people from various walks of life, they were interviewed, and it was around 6,000 people from various parts of China, rural and urban and small towns and big cities. And they were asked what their reactions were asked on this medical violence. And this is 2018. And more than 4,200 pollsters, I mean, people who were surveyed, they said they were sympathetic and they were happy that people are actually taking some action against this unfair healthcare system and healthcare professionals. I mean, this is something which is shocking, that out of nearly 6,000 people, 4,200 people said that they were very sympathetic to those patients or their relatives who had no other way but were compelled to indulge in these kind of violent activities. So, and this I'm saying it in the context of, and what has been the attitude of the Chinese government to tackle this problem in that context, because even in early this month, when there were 2 sessions held, one of the NPC deputy, he actually moved a note in the NPC session asking the government to implement strict security measures, like every hospital must have the security check before letting anybody inside the hospital. And in his note, he gave some data also, that in the last 2 years, in nearly 22 hospitals, big hospitals, government hospitals in Beijing, when these security checks were introduced, that in last 2 years, out of 22 hospitals, 180,000 items were captured, which were not allowed to be taken inside by the patients or visitors to the hospital. 180,000 items, which included axe and hammers also, right? So, so in this context, if I may ask you that, especially you mentioned about 2009 healthcare reforms, and the latest reform, I think, correct me if I'm wrong, were introduced in 2015. And if you look at both, the first, which cannot be called actually a full healthcare reform package in 2003 after SARS, but then the 2009 one, and then 2015, both these reform packages actually were more aggressively accelerating towards privatization and commercialization of healthcare. And that is one side of it. And second side of this is that it's such a huge nexus, as you also mentioned about the corruption and big pharma involved in because the hospitals now have to earn their own resources. There's no government funding or subsidies being given to them. So they are in close links with the big pharma companies, from where they get, even individual doctors also get huge bribes to promote their medicines or to write more prescriptions of their medicines, etc., etc. So in that, I just want to mention that in last year alone, I mean, the COVID year 2020, the only sector which actually prospered and flourished in terms of big foreign pharma companies or corporates entering China and getting licenses, actually was 137% growth over 2019, despite IPR issues, despite trade tariff problems. This is one sector which actually flourished in China, and this also reflects on in such a big way the privatization and the nexus between the big pharma. I mean, all even Goldman Sachs healthcare group actually is the most active, and Bill Gates also, and there are other like Pfizer and VB and Bayer and Roche, etc. And they're all very much in touch with hospitals and government officials, both at the local level as well as at the central level, etc., etc. So what I'm basically asking is that if the healthcare has become really so out of reach from common people in China, then how do you look at this side of the development of the corporate? I mean, the China is now, China is now the second largest market for pharma and such industry. After, I mean, it replaced Japan recently. After America, China is the biggest pharma market of, I think, $140 billion market in China. $140 billion. So please tell us more about it if you.
Yeah, so I mean, I would actually, all the points that you brought up, I would like to put it in a systemic kind of a perspective, because violence itself can't be seen as something separate from what's happening to this sector systemically. I mean, even in my article that I had written in 2015, I say, like, my subtitle was, "It's a symptom of a deeper crisis." So that crisis has been emerging in China since the early 2000s. And even before the 2009 reforms, we see the systematic commercialization of public hospital reforms and also the financing system itself. So you shift into an insurance kind of a system, which is, I mean, in a sense, not free in that sense, because the government subsidies are still less in the insurance schemes. So you have these three parallel insurance schemes that come up to address the universal coverage of people, but actually in terms of depth, that's pretty limited. So the government subsidies aren't enough. And you also see inequalities in access through these insurance schemes. So post that, when you see like there's a rise of medical costs and the rural people and the marginalized are actually, bearing the brunt of medical costs, while the urban employees are pretty much comfortable, especially in the first tier cities. That's when the government makes these 2009 reforms. So those were supposed to be corrective measures. But really, what can you undo here? Like, in the sense, once commercialization, I mean, that's what Rama and I have questioned in our books too. I mean, is it a irreversible process? So once you start getting into this process of commercialization, like, what kind of corrective measures do you actually put in? So you can just, what you do are just band-aids in a way, you just move ahead with smaller steps, just probably, addressing some parts of the health sector, but not a complete response to the systemic failures that the system is facing. So you see that in all respects, whether it's drugs, whether it's financing, whether it's provisioning. And the final thing is actually what gets affected is the caregiving process. So even this caregiving process, like, medicine has to be seen beyond literally, the term medicine. It's not just about medicines. So this is about care. You are going to an institution to, seek care, and you trust yourself, because there's an unequal relationship between a medical professional and the person who is going to seek care because of the difference in knowledge and the technical know-how. But more than that, there is also this whole, realm of care that you are going. You want to feel that satisfaction. You want to feel that you can trust the person you are going to for, whatever health related illnesses you have. and whether it's a chronic or an acute condition or whatever. And that is something that has eroded over a period of time in China. And that is what has brought in. So the fact that people, I mean, I see like both the medical professional and the patients who are visiting, or the people in China, both as victims of this whole process, the whole health service structure itself that's evolved in the process. So reactionary measures like having security, I mean, that's something like even in India we have done, calling, I mean, you have these very one-off kind of knee-jerk reactions like, okay, increase the security of the hospital. That just becomes just addressing one, symptom, but actually you are creating a further divide between the patient and the healthcare workers by already, you're already mistrusting the person who is entering this institution to seek care. So, I mean, how do you address that phenomena itself, So I think it's a deeper issue here that you have to address. I mean, of course, it's the whole process, the political, in fact, even 2015, I mean, the 16, whatever the reforms were about, were also about further corporatization of the public hospitals. So once you have commercialized, you further corporatize. I mean, you can't privatize them because the ownership is still public, but you further corporatize them, and you also have kind of involved a larger private sector that is opening up now in China. Unlike India, I mean, China doesn't have a heterogeneous private sector. I mean, it's now opening up, and you have opened up to private investors.
From 2016 onwards.
Yeah. That's 2000. I mean, I would say post Xi Jinping. So 2012, post that. So, I mean, I think these are the important issues that and one has to look at it very systemically, because ultimately it's the caregiving process that's getting disrupted.
Okay.
And yeah.
Okay, thank you so much. And now I think you've also given me a lot of food for thought and asked a couple of questions to Professor Maitrayee Chaudhuri. I mean, as you must have heard Dr. Madhurima Nandi's perspective. Now, the interesting, I mean, not interesting actually, the disturbing thing is that in China, I mean, China's criminal law, ironically, has no provision that actually specifically covers punishment for people indulging in medical violence. On the other hand, and this many Chinese lawyers who are actually social activists also and are involved in such cases which involve the medical violence, even they have been repeatedly writing about it and pointing out that the government, since government is very particular about maintaining social stability. So whenever such major incidents happen, like in January this year, a 38-year-old cardiologist was brutally murdered in his own chamber inside a hospital in Beijing. So that created a lot of almost kind of a storm on China's social media, and a lot of questions started being asked about what the government is doing. So in such cases, what the government does actually is, in order to maintain social stability, it pressurizes the hospitals to immediately give some kind of a compensation to the patient or the so-called victims, so that the matter is hushed up and it does not blow up into something more serious. This is the attitude on the one hand, and on the other hand, and there are now one can say that enough number of studies done by Chinese scholars themselves, Chinese sociologists, Chinese social scientists, etc., who are looking into these issues, and they are saying that for years or for decades, Chinese government actually has treated this problem as a law and order problem, whereas this is actually a social problem. This is not a law and order problem. So since you have been actively involved in similar issues in India also, and you told me earlier about how prevalent this phenomena is in West Bengal. So how do you look at it? I mean, how do you look at it, this government's policies in either not actually tackling these issues, or maybe perhaps helpless because they want to promote privatization or commercialization of healthcare at the same time? Unmute yourself.
No. Yeah, thank you very much, Hemant. And I'm glad that Madhurima has given us a very exhaustive sense of what's been happening in China. And as I mentioned earlier, that I had very little knowledge about the specificities of these attacks in China. So where I would come in more generally and perhaps more specifically to the question which Hemant has posed to me about what the government does in such situations, that it does not have any provision for punishing such assaulters of medical violence, but would like to hush it up. And perhaps what Madhurima has already mentioned, that this is a band-aid approach. And this band-aid approach is perhaps something which is not specific to China, but it is much more general, because as she put it, I think she laid the ground that there are certain kind of structural imperatives and logic of commercialization, which would, naturally lead to certain kind of helpless situations. The point I would like to enter in is that there is a distinction perhaps between the kind of the scale of violence in China, which of course I'm not fully familiar with, and perhaps what in India we have this fable attitude of resignation and patience.
If I just intervene here, just to tell you, because you mentioned this thing, according to the 2018 figures, in 2018 alone, 17,000 cases of medical violence took place.
In China, yeah. So the scale is obviously a completely different order, perhaps than the scale over here. Now, what I wanted to say is that China, as you've all mentioned, had for long years a certain understanding of a state, which was, committed to provide certain kind of welfare measures, whether education or health, and there was a structure in place, which was dismantled. So people were used to certain understanding of, if you go to a hospital, what you would expect. Now, in our country, for example, in India, the kind of description you gave when you went to AIIMS with your father, and I could give such descriptions when I went to AIIMS, it's not that we didn't feel the urge to, actually do something physical because you are so desperate. That sense of helplessness is acute. But we have or also socialized in a fashion that this is how it will happen. This is how it is. Whereas perhaps the transition in China is much more abrupt and disruptive. So I think the contexts are different, So if I have to speak from a sociological perspective, is the contextualization, which would be very, very important. There are certain patterns which are common. And the pattern, I think, Hemant mentioned about crisis, and I think Madhurima mentioned about crisis. And say from the disciplinary location that I come from, sociology is very intrinsically related to a crisis. It emerged in a crisis. All the writers who began sociology would talk about concepts like anomie, which Durkheim talks about, alienation like Marx, or Weber, estrangement. The sense that the individual is separated from the larger social structure, a sense of helplessness which is acute. And I was looking at some of the videos which you shared, Hemant, and very often in the reportage, there is that fury, that sense of surging anger, which makes people do these things. The sense of complete helplessness. And I think that's important. And I was curious here when Madhurima mentioned it, or was it Hemant, that it's not necessarily a spontaneous anger, but sometimes you have an institutionalized alternative hiring of mobs. And you gave the examples of the security finding knives or hammers being put in. So what is happening here is, from what I can sort of visualize, is a set of people, and I think Madhurima put it very well, both the doctors and the medical system and practitioners who were socialized and trained in a particular way, now having to shift gears abruptly towards a revenue generating model. And the patients were expected to go to these medical systems for care, now suddenly realizing that it's a different ball game with agents, money, long queue. In both cases, you are being differently located of privilege and vulnerabilities, but in both cases, you are left on your own. And that's the whole neoliberal model, even if you call it market socialism, that you have to do it yourself. You have to depend upon your resources. However, the institutional resources have broken down. There is no institutional resources. You can't go to the state and say, look, this is wrong. The state is going to look at it as a law and a problem. And you said, and you put it, the stability is the issue. So all these are irking problems which disrupt the stability, but not the rights of a citizen to demand these of the state. So the language has changed. So people have to then depend upon their own jugaad in our Indian context to figure out which agent should I go to. And in the Chinese context, obviously the medical, because the medical has also a specificity, which is perhaps different from education or different from any other sector, where you also have agents. In our own country, it's not been exceptional that there have been parts, and I hope we don't join those ranks, where somebody could come and tell the teacher, listen, you better pass me, or, it's not unheard of, because when institutions collapse, then this ability of the individual to figure out or cope up or manage is going to come to the fore. The institutions are not there. And if the institutions are not there, initially it could be the stray anger. But when stray angers repeatedly cannot get resolved, then perhaps you have an alternative system, which is underground, which works to equip you. Just like agents are not legitimate. But maybe the agent has a deal with the ones who will come and, there would be an entire, and in our country, a lot of it is there. It's not that it hasn't happened. You do have a system. If I've been trying to negotiate with a mutation of a DDA property, and if you go to a DDA office, you know exactly what it means to be completely vulnerable, helpless, with no say at all. So your dependence on all these characters become therefore extremely acute. So I think there are certain general patterns which are there whenever the individual is completely helpless.
Yeah.
And the individual is helpless, particularly in a system where she or he had not earlier felt helpless.
Okay, thank you very much. And if I pick up a thread from what you said earlier, when you were referring to Weber and also from the sociological perspective, and you talked about crisis. And here, Chinese scholars also in their writings, they have referred to Weber, and they've actually used a particular phrase, which is appropriated representation. And this is a typical Weberian phrase, as I gather from the Chinese writings. And the reference is that the Chinese state or the Chinese authorities have actually abdicated their responsibilities towards these issues. And they have passed it on to specialized institutions, which may not be part of the state. But of course, state or party has control over them. For example, in this particular case, is the China Medical Doctors Association. Such cases are actually referred to them. Or in the case of labor-related issues, it is given to the All China Federation of Trade Unions, etc., etc. So on the one hand, you have this way of dealing with these problems that don't come to us, you solve it yourself. On the other hand, when the situation seems to be getting out of hand, then suddenly the state intervenes and tries to patch up the thing by asking either the hospitals to pay the compensation, etc. But the problem continues. I mean, this is what I'm trying to point out, right? And it's kind of a, using again the Weberian reference, it's kind of a fixing of the problem, right? By this way or that way, but not actually addressing the issue in its genuineness. So, and that is what has become a very common practice in China across sectors, not just in the healthcare sector, etc. And that is one reason why these things, Chinese scholars themselves are saying that these problems have become chronic social problems rather than, anybody seeing any efforts on the part of the party or the state. So how do you then actually, because on the one hand, it's not my words, I'm just quoting Chinese writings. They say that it's actually not socialist China anymore. It's a China which is ruled by the Communist Party, but it's not a socialist China. I mean, how do you look at it? China being a different model, socio-political, economic model than India. Of course, all kinds of ills which we can see or experience in our medical healthcare system are there very much in China also. In fact, perhaps on a larger scale. Your answer.
Yeah, no, if your question is a very broad question about the nature of the Chinese state, it's obvious, isn't it? It's self-evident. So if you have probably a state which is whatever they call it of market socialism, but it's obviously, like you said, the whole issue of how it operates is very different. But more importantly, it's perhaps, the question of protest or resistance. Because I was reading up a little bit of those things which you circulated to me, and some of them refer to Scott's Weapons of the Weak, arguing that when you have a retreat of movements which are based on solidarity or collective visions, then you have protest. I sort of was looking up, I went back to Scott, and I'm not totally in agreement because what Scott was arguing is that when people are really helpless, then they negotiate, they adjust, they try to figure out, give limited goals and operate with limited means. What is happening here is, it is the weapons of the weak, but the whole idea is, it's not managing. The situation is so stark and so grim. It is not just managing with the limited possibilities, but trying to figure out in a more violent fashion, what they can wrench out of that system. And also the point which I found from Scott useful was the question that when they attack the doctor or when they attack a nurse or anybody in that system, they are tangible human people whom they see as the perpetuator of all the ills that affected them or their families, And now it's very difficult to fight against capitalism or neoliberalism or the Chinese Communist Party, but to catch this fellow whom you feel is the source of your problem is much more real and much more experiential, So I think it's also related to do with human experience and the ability to identify the villain of the piece in a more tangible fashion.
Okay, so now this brings me to a final common question to both of you. And you will be, I'll request you to stick to maybe 1 or 2 minutes answer so that we can then go to the question and answer round. And the question is that just now when you said that about your comment on the weapon of the weak, now let me turn this argument on its head and quote the Chinese scholars themselves who are saying that actually the whole thing can be explained as the weakness of the strong. And the weakness of the strong here is reference to the state or the party. That party has become so vulnerable in order to be very focused on its legitimacy being extracted from the social stability factor, that it is now very vulnerable towards this kind of social phenomena. And then it actually incentivizes this violence to actually perpetuate. So that is some explanations given by the Chinese scholars that why party continues to be unable to actually solve this problem. So I think it's a very interesting formulation of the weakness of the strong, and the strong here is the party or the state. So let me begin with Madhurima here first, especially from the commercialization point of view.
Yeah, it's an important point, definitely. When you say the state itself is feeling vulnerable and is weak enough to kind of, even address these severe issues that are happening in the society. And, rather than overhauling the system, which they are unable to do because there are so many different interest groups that you've already created, and the commercial interest itself is so embedded now in the systems within the healthcare itself. So how do you kind of dismantle that now to, create a more equitable and universal system of care? So that is something they are constantly. So you see the Chinese system also, the state is continuously trying to put in corrective measures, by wanting to build the primary healthcare system, by trying to address the corruption issue, by trying to tell institutions to, disincentivize the doctors. I mean, where the medical professional shouldn't be, so they are kind of hauled up by the management if they see that there is corruption happening at that level. But obviously, I mean, these become very symptomatic things. I mean, you're addressing just the symptoms, but not the larger issue at hand. I mean, you have actually, in a sense, created a monster, but you don't know how to tackle it with multiple heads and multiple hands. So, you kind of have these different layers of whether it's in financing, you've created an insurance system that's not accessible to everyone, that's not universal, that completely lacks depth. You've created provisioning, which is highly commercialized. You've created a pharma industry, which is also highly commercialized. I mean, even the domestic industry itself is highly commercialized. So you don't have a generic kind of a system that we have, a generic pharma system. And yeah, I mean, so the state itself is in a bit of a, I mean, the fact is, like, at least unlike the Indian system where you don't even address what's happening, you've already it's all so messy that you don't even know where to address things from. The Chinese, you see the state constantly addressing the issues, whether it is care, whether it's the health services, whether it's aging, care for the elderly, so those things are challenges to them which they know they need to address. But then it just becomes very, what do you say, not a very comprehensive way of looking at it, looking at the entire picture in that sense.
Okay. Thank you so much. Maitrayee?
Very quick two responses. I think when you said the weakness of the strong state, all authoritarian states are very vulnerable, is one. And second, I think the point that Madhurima mentioned, that the Chinese state has inherited an older legacy where they feel they have to do something to address the issue. And therefore you're caught in a bind, but you can't, because you already, or the pedals are already on a very different model, so I think this becomes an almost impossible situation.
Thank you. Thank you so much to both of you. Now, I'm sorry that we've eaten into the time of the question and answer round. Let me begin with requesting Partho Mukhopadhyay. I think he has raised his hand. Partho, are you there?
Yes, I am. Thanks, Hemant.
Yeah, please ask your question.
Sure. This is quite fascinating. So, 2-3 kinds of things. One, I'm trying to get a sense of what was there, let's say, in the 1980s and 90s, and my reading of the Chinese literature on health provision seems to indicate that it was not very well provided. That you had a pretty, it wasn't a particularly widespread access to public facilities. It was, a large section of the population in China didn't really have access to Western healthcare for a substantial amount of time. And then as Western sort of medicine started becoming more accessible, it became accessible in a relatively unequal fashion. And the insurance reforms were designed to sort of move into a situation where you would like to broaden the access, but the insurance story was essentially done at a level which was well below what was sensible. I think it started at the county level and then sort of moved up at most of the provincial level at certain places. It's never really been a national insurance scheme. which then created a fair degree of trouble in essentially making it financially viable in that sense. So that was one part of the story. And the second part of the story is the kind of the weak state story that you're talking about, Hemant. The Chinese state has never really, it has been a relatively low tax state and has never really spent too much on quote unquote services. There's been a large amount of expenditures on infrastructure and things like that, but not very much in social services. So as such, they were never really willing to finance a widespread, accessible provision of medical care to a large segment of the population, even when they have become relatively wealthy. The quote unquote, the moderately prosperous society is now facing the trouble of the fact that its institutional mechanism that it had put forward for healthcare is not something that can provide the quote unquote, let's say, but even a partial kind of the Scandinavian kind of widespread access to healthcare that there might be an ideal in a moderately prosperous society. So, so that's one thing, and therefore that I think is a structural policy issue. And I'm just wondering whether, to what extent Madhurima would agree and Rama would agree. The other issue is this issue of violence against doctors, and that I find, I mean, increasingly as I heard the discussion, I was reminded of India, because this is almost entirely the, I mean, my friends who work in the healthcare sector tell me that violence against doctors is a standard method of ensuring a certain level of care in public hospitals in India, because the threat of violence essentially makes sure that you will not do anything too nasty to my patient, kind of story. Right? Now, if that's really the case, it's not so much the privatization story. It is essentially this whole issue of information asymmetry between the doctor and the patient, and the lack of trust in the system that is actually delivering this particular story. So that's where the problem is arising. That the lack of trust, at least in India, seems to be equivalent whether it's happening in the private sector or in the public sector. In that structure, I'm just wondering whether that is also something that is happening in the Chinese story going forward. If so, the diagnosis of what the issue is then becomes somewhat different. Okay. And therefore might have sort of different sort of prognosis going forward.
Okay, thank you, Partho. Madhurima, would you like to comment on that?
Yeah, I'll first start with what Partho mentioned at the end. The issue can't be separated, I feel, like the interpersonal relations that I spoke about between the physician and the patient, where you have an asymmetry of information. Definitely that's part of the thing. And but you have to see it in the larger context, even within India, of privatization and commercialization of the health system. So public hospitals, even within India, are facing a lot of crisis. There are lack of subsidies there. There are a whole lot of waiting lines, people traveling from all over coming to seek care in public hospitals. And the private, as we all know, is commercialized. I mean, we ourselves as individuals seek care through our known people. You know, it's something called medical guanxi in China. So where you are actually looking for for doctors whom you know. So you would actually go through those pathways to seek care, because you can't trust anyone and everyone within the medical profession or enter any institution seeking care. So I think it is a larger issue here, definitely. And world over, I mean, since we have been saying it's a global phenomenon. I mean, India, even I know the Indian Medical Association had reported 75% of the healthcare workers have faced some kind of violence or the other. But the world over, even in England, where you have a system like the NHS, violence is I mean, they are not like violence is not absent in their health system either. But NHS has also gone through several transformations over the last few decades, and you have a whole lot of issues and financial issues with larger privatizations happening, with contractual work. I mean, everything that's creeped in there also, which are also like parts of the commercialization, issue. Similarly with the United States, I mean, I guess one is aware because we keep talking about the United States. And in fact, yesterday I was listening to a talk where, I mean, Rama was also part of it. So where they're talking like United States, I mean, 2 years back, they had done this ranking of countries where you're actually looking at how much is the pandemic preparedness, and US actually was at the top of the list of pandemic preparedness. And it's actually, I mean, been the worst in terms of how they have responded to this pandemic. So there are issues here. So you are, I mean, looking at the kind of care systems you have. I mean, US has created this whole managed kind of a care system, which is so regulate with all kinds of regulatory mechanisms. So you have these very codified structures of how the patient and how the physician behaves with a, patient. So you have this whole managed care insurance model there, where the doctor actually, there's a kind of a defensive attitude or defensive medicine, you call it, where you use all kinds of, you over medicalize, you overdo things where you have to, because the system wants you to do that. Because if you fail in giving something which the patient had sought help or, had said, like, this is something we were looking for, or this is what we want. So you're far away from rational care in that sense. So there's a lot of irrational behavior within these systems that's happening, which I feel is perpetrated by the larger process of the health systems.
Okay, before I request Maitrayee to comment on this, let me quickly point out that there's also a real problem actually of the lack of doctors or adequate number of doctors in China.
That's true.
Latest figures suggest that against the WHO average of world average of one doctor per 1,200 or 1,400 people, in China it is one doctor per 6,000 people. That is one. And second, and Chinese scholars have pointed out that because of this growing menace of medical violence, actually the less and less number of Chinese people are now coming into this profession because of this problem itself. So, Maitrayee?
No, I really don't have anything to say directly to this, but the point which, Madhurima mentioned in her response, which I found of interest, is when she said that we as individuals also like to seek out somebody we know. And the point that she had earlier mentioned about trust, now, this again indicates that sense of helplessness, We are not very comfortable, or whatever be the system, the public or the private health system. There's a certain kind of de-link and anonymity and the logic of commercialization. We're always suspecting that maybe this was not required. Now, to understand that, obviously, it is the entire model upon which this rests, and our responses as just clients or patients, in this whole game, wherever it be.
Okay, so let's take some questions from the chat box now. I think Patricia wanted Madhurima to elaborate a little bit on the insurance aspect.
So, So I mean, I link it up to Partho's earlier first comment. In fact, like 1980s and 90s, what was happening in China. So you actually post the dismantling of the collectivization. The health service structure also dismantled. So this was the early 80s. So throughout the 80s and the 90s, you see a kind of an anarchic kind of a health service structure where there is no intervention. The subsidies are withdrawn and institutions are struggling to be on their own. And the revenue generation had started much before the 2000s, in fact. So in a sense, every institution is trying to survive because there are no subsidies by the government. And the medical care costs by the end of 90s rises so much that it's almost like creates it was a major societal concern, and even for the CPC for that matter. So that's the time when they think about bringing in how to, so these are, again, I would say as band-aids, because you're not actually trying to rebuild the entire system or investing more on the health services, but you try creating reforms through reforming the financing system rather than looking at it, systemically with the provisioning and all. So what happens is you start with insurance systems. First, the rural insurance system is implemented in the late 90s. Of course, it's not universal. It's very targeted. It's kind of, there's a lack of government funds that are there, but you kind of launch it and to give some respite to the rural people, rural poor, especially the ones who stay in far off provinces. But of course, I mean, things didn't take shape, so soon. Things didn't improve immediately. So post that, then they kind of build in further two reforms and bring in other insurance schemes for the urban dependent as well as the urban employees. So these three become parallel schemes which completely don't speak to each other. And they are iniquitous. They have different weights given to them. The depths are completely different. They aren't able to broaden the scope of these insurance schemes, but they try to do that by the mid 2009 and 10. That's when they say 99% of their population is covered. So in terms of insurance, the citizens were all covered, but then again, there was a question of what are the services they are getting, and are they able to access services at their doorstep or, through the health centers that are there near the place. But that was not happening because the primary level was completely broken. And all the rural population was actually going to the cities to seek care. And in that sense, when you're going to cities, then the hukou was something that was, again, impacting on these people because you weren't able to access care directly without paying out of pocket. So you are actually paying out of pocket when you are shifting from one province to the other for looking for, better care. So these are the aspects of insurance. And I feel even now the insurance schemes are such that they haven't been able to broadly, they have universalized it in terms of the population being part of the schemes, but they're not able to provide all services within, free of cost. That's definitely not been the case. So access, out-of-pocket expenditure is still a big issue in China.
Okay, there are two quick questions in the chat box which I may mention here. One is about whether this phenomena of medical violence is confined to only the Western medicine in China, or it also includes the Chinese medicine experts, etc. And the second question, I think, is specifically addressed to Madhurima, which asks whether this medical violence in particular increased during the COVID period, or it was there earlier also?
For the last question, it was definitely there early on. So it's not specific to COVID, definitely.
Yeah, of course.
Yeah. So I in fact don't know what happened. Hemant actually gave an overview as to what was happening during the COVID period. I haven't yet looked at violence that would have occurred during the COVID crisis. But I'm sure even they face the same issues as we have in the sense of a disruption in daily care and, in normal seeking care and a lot of focus on COVID. Regarding I think it's mostly the biomedical system that's been, because this violence is also, you see, at the tertiary level. These are bigger hospitals that are the major, like the hubs of such violent activities, because that's where the crowd is, that's where the people are going to. And to seek.
In fact, I'm sorry to interrupt. I forgot to mention in the chat box in the beginning, before the discussion started, I put a link to a video, another video, which is again a short video of 2 minutes or something by a Chinese newspaper called Sixth Tone. And that is also a reflection of this phenomena. You can actually look at it now or later. This is how a medical team actually attacked a journalists group who were reporting on that hospital in Shenzhen. And there's actually physical fist fighting going on between the medical staff and the journalist who had gone there to report on one particular incident. So any more questions anybody has can straight away ask by raising hands or just saying that you have a question, since we are now running out of time and very soon we are going to wind up. Anybody's question is welcome.
Hi, Hemant, can I ask a short question?
Please, please.
So I was just wondering, given the tradition, the Chinese tradition of sort of reform in small places, are any provinces doing anything interesting in this regard to address this issue? Or is the current climate of quote unquote one China, has that sort of stifled that kind of local innovation in China?
I can quickly come in here and say that, for example, Shanghai took the lead in this 2 years ago when they introduced certain measures in order to check this growing menace or discourage people indulging in this kind of medical violence. For example, now, as you know, there is a social credit in China being implemented. So as part of that, anybody who is indulging in this medical violence will be barred from either sitting for the exam for the recruitment of civil services in China, or even getting benefits out of the healthcare insurance. So individual provinces have actually started taking up some of these measures. Shanghai took the lead 2 years ago. Yes, Madhurima?
Yeah, no, I just wanted to bring up this work by Arthur Kleinman, actually, because he's a psychiatrist by training, but a medical anthropologist who's in Harvard. And he has, in fact, worked with a team at the Sun Yat-sen University, where he actually addresses the issue of trust. And this between the patient and the physician in China specifically. And he has done extensive research along with these Chinese colleagues on the issue of trust. And of course, I mean, they also see it at different levels, but they feel like there needs to be a certain intervention to rebuild this trust. There's a deficit of it within. And trust itself is a social science concept, I feel, because you have to look at it in terms of the larger trust deficit that's there in society in general. And that's how they talk about also. So you have the social transformation happening in every city and the individualization of societies. And then you have this issue of trust. I mean, we see it in international affairs also. We kind of constantly are bringing it up in interstate relations or intercountry relations and all. So the trust deficit is important. And this is what you're seeing at the micro level, what's happening at the society. So Kleinman's work, in fact, is something that's very fascinating because they have done workshops with doctors, physicians, as to what it means to develop. So that becomes like, again, like you're addressing one part of it, but you're also trying to bring back this issue of trust between the healthcare workers itself as to how to be, compassionate within this system that's already so broken and fragmented. But what is your concern as a physician? Like, how are you going to look beyond the boundaries of just, providing band-aids for illness and all, but how do you actually go beyond those boundaries? And also the whole issue, like not making it a daily routine kind of a process where it becomes very mechanical kind of a thing, like, because of the waiting system and because you're just able to spend just 1 minute per patient, but how do you make that 1 minute also meaningful in a sense for the caregiving process itself? So Arthur Kleinman's work, I think, actually talks a lot about this process of violence specific to in the Chinese context. And he has done a lot of work on madness and all in China also.
Yeah. Okay, Admiral Muralidharan.
Thank you. No, I just wanted to add a point. I noticed that the old Soviet Union had managed their healthcare very well, even in the most remote areas. and it was totally by the government. And so did, in fact, at least 10 years ago, I knew that Russia had managed very well, while the foreigners or those who are diplomats who were there, we had to pay for the healthcare. But the average citizen of Russia had basic healthcare, even in his remote villages, managed very well. I'm surprised that the Chinese did not copy that model into it.
Okay. Okay, as we are now nearing the end of the discussion, so I would request our experts if they have, anything to say in their last 2 minutes for the discussion as the wind-up thing. Maitrayee?
No, really not. This has been fascinating. I was more a listener because, this is an area I'm not familiar. But I think it's a lesson for all of us, And I was very struck by this idea of trust, and how do we build up that trust? And the gap between an institutional structure, which, to use your word, Madhurima, is already fragmented the possibilities of that trust. So how do you rework on that, and what could our role be as academics in that sense towards that, perhaps more research on it to figure out exactly all the elements which go into this kind of phenomena. But thank you very much for this opportunity to listen to this fascinating account.
Okay. Madhurima?
Yeah, I don't have much to add actually, because there are different levels and different layers to this, and I guess one has to address all of them systemically. And but even from the Indian context, I can say there's been a shift. There's been, in fact, my own doctoral thesis was looking at the shift in the nonprofit hospitals within Delhi, and trying to see over decades how there's been a trust deficit, or there's been a further commercialization of these institutions. So in that sense, it brought back, in fact, when I was reading a lot of stuff, it brought back a lot of my doctoral work that I'd done and seen the transformation, the social transformation of these institutions, actually, per se, and how it affects the culture of medical practice itself. So that's something I think that needs to be understood in a holistic way. Yeah. Thanks.
Okay. As we wind up in my concluding remarks, let me also point out, otherwise I think it will be unfair, that there is a school of thought in China, and there is a definite discourse in China, which is still advocating for the full going back to the universal and free healthcare, and moving away from the healthcare reforms which are moving in the direction of commercialization of healthcare. And in fact, last year, I remember during the 2 sessions in May 2020, one NPC deputy who happens to be also the director of the Beijing government's biggest hospital in Beijing, and was also nominated to the NPC by Beijing government. He actually moved a note last year in 2 sessions in NPC, asking for a complete moving away from the public hospitals. Public hospitals in China basically means private hospitals, and going back to the earlier system where people don't have to pay other than their minimal registration fee, etc., etc. And there are others also. There is Professor Li Ling, who is a very well-known, in fact, she is a lone crusader who has been writing, very, very prolific writer, and she actually has taught and also worked in Princeton, and then taught in Hong Kong, and then she's now, she was also China's nominee to the World Bank Healthcare Group, and she's also part of all the major policy decision-making meetings, perhaps as the lone voice who is not in favor of these kind of healthcare reforms which are being implemented in China. So that gives perhaps some kind of a credibility to the policymakers, that they also have somebody who does not agree with them, and they give a chance to that person to voice her opinion, etc. And Professor Li Ling actually is also a member of the China's NDC, National Development Council, etc. She's a very, very powerful figure as far as the healthcare sector policies are concerned in China. So there have been voices, there have been frequently articles being written by professionals, by scholars, debating these issues. So it's not that it's just one-sided. That's what I also wanted to mention this point. And lastly, as I said in the beginning of today's discussion, that this is a kind of experiment we have taken, a sub-series within the ICS Wednesdays seminar series of bringing up issues of social problem in nature in China, and which are not actually getting the attention due to these issues in discussions outside China, especially in India also. So we have already identified certain issues, and we hope that we will continue this sub-series by holding such webinar discussions once in 2 months or once in 6 weeks. 6 weeks. The basic purpose is to flag these issues, to highlight these issues, and invite experts so that some kind of a dialogue or discussion can be started on these issues, which we think that does not get its due attention. So that was the purpose behind this thing. I'm very thankful to all of you for participating in today's discussion. Despite, I'm sure many people are busy getting vaccination done and jabs, etc., etc. And since there is resurgence also of this COVID-19, uh, keeping all this in mind, once again, thank you to all of you for participating in today's discussion.
Thank you so much.
I also thank our young IT team in ICS and the director for organizing this webinar, and to our two experts, especially Maitrayee, who at a short notice, and also first saying that she's not a China person, so what will she speak, etc., etc. I think it was very, very enlightening to listen to you, and also especially the comparative references. With these words, I thank you all and announce the close of this discussion.